Impact on the Stigmatization of Individuals with Sickle Cell, Challenges and Recommendations. Dr. Corretta Jenerette earned a PhD and MSN in doctoral fellowships at both Yale University and the University of North Carolina at Chapel Hill. She is a certified nurse educator. She's developing a program of research aimed at enhancing self-care management in vulnerable populations such as individuals with sickle cell disease. Specifically, she uses both qualitative and quantitative methods to identify vulnerability factors in order to intervene by enhancing self-care management resources with the goal of improved health outcomes. Dr. Jenerette is a board member and vice president of the International Association of Sickle Cell Nurses and Physician Assistants. And now I'd like to turn the webinar over to our presenter. Dr. Jenerette, please unmute your line if you haven't already by pressing *6 at this time, and you can address the audience.
Hello, everyone. Shay, can you hear me?
Yes, we can, loud and clear.
Wonderful. So good afternoon, and thank you for taking time to take part in this webinar. And if you will advance to the next slide. So these are the objectives of the talk. First, I will define stigma in the context of sickle cell so that we're all considering one definition. Then, using data from a few of my studies and those found in the literature, I will describe the nurse's role in stigmatizing individuals with sickle cell and discuss challenges and provide some recommendations to decrease the stigmatization of individuals, particularly patients with sickle cell disease and those who are in pain and seeking care. So, first, the definition. Health-related stigma refers to a form of devaluation, judgment, or social disqualification of individuals based on health-related conditions. We know that individuals with sickle cell disease have described feeling less than human when their complaints of pain are ignored or discounted as false by healthcare providers. In fact, my interest in subsequent research in the area of sickle cell disease began based on my experiences as a new nurse in an adult medical oncology unit more than 20 years ago. I certainly saw reports of pain ignored and the labels of drug seeking. Unfortunately, I still see the same kinds of responses today to patients with sickle cell, despite the numerous advances in the provision of health care to this population. Much of my research has focused on young adults because these individuals tend to be the most vulnerable. Young adults with sickle cell disease, especially those between the ages of 18 and 30, have the highest rates of ED use and the highest rates of rehospitalizations. In a recent paper, 2010, we highlight some of the challenges for young adults with sickle cell disease, such as issues in childhood, lack of transition, issues with finding a medical home, etc. So I would just suggest that you keep these in mind as we explore some of the challenges and offer some recommendations. So, are you familiar with the stereotypes associated with individuals with sickle cell? Mainly adults. Have you ever used or heard healthcare providers use the term sickler or frequent flyer to describe a patient with sickle cell? Do you feel that compared to others who seek care for pain, that individuals with sickle cell are more or less likely to be drug-seeking? Stereotypes, labeling, and perhaps even profiling lead to health-related stigma and less than desirable care-seeking experiences for individuals with sickle cell, especially those in pain. So, in the context of sickle cell, I would like to make the case that the village is the healthcare system. We know that many patients with sickle cell disease delay care-seeking or leave the village too soon due to past treatment or inappropriate care. Just to further the point regarding delays in care-seeking, these were the top 3 reasons offered by a sample of young adults with sickle cell. So the number 1 reason that they delayed care-seeking was that they are taught to try to manage their pain at home as long as possible. In fact, a 32-year-old woman stated that she tries to manage pain at home because she wants to make sure so she won't be discharged only to return. The next highest reason given was trying to avoid the ED due to past treatment. A 29-year-old man stated he tries to manage his pain at home because he already knows what will happen at the emergency room. And finally, the third most frequent reason was wanting to avoid a hospital admission. An individual stated that hospital admissions did not fit into their lives, as both females and males did not want to miss school, work, or fun in general. These reasons for delaying care seeking certainly do not match the stereotypes. Do they actually describe people who are drug seeking? So now, let's move on to the role of nurses in the stigmatization of patients with sickle cell. Note that nursing is the largest healthcare profession. Moreover, nurses have been rated as the most trusted profession by the Gallup poll for 11 years in a row. The only time nurses were not ranked as number one was right after 9/11, which is certainly understandable. This word cloud reflects some of the characteristics often associated with the profession of nursing, and you see prominently there care, nursing, environment, personal values, beliefs, all those things that we come to think about when we think about the stereotype of nursing. Keep these attributes in mind as I share the results of a study that provided some quite interesting results that contrast these attributes. At this point, I always like to remind everyone that I am a nurse. So, I conducted this study comparing attitudes of medical surgical nurses and nurses that work in either the ED or ICU. The purpose of the study was to better understand nurses' attitude toward patients with sickle cell. In general, this is not a new idea, but I added the issue of comparing the results from nurses who practice in either the ED or ICU and nurses who practice on inpatient medical surgical units. Note that nurses are often the first healthcare professional a patient with sickle cell encounters when seeking acute care, such as in the ED. The nurse can be considered a gatekeeper and often triages the patient and plays a significant role in determining the level of care and perhaps the timeliness of the provision of care. ICU nurses were included to increase the anonymity between the sites for data collection. Regarding the care of individuals with sickle cell disease, a lot of attention is placed on the ED and perhaps the stigma that can occur there. However, care often extends beyond the ED, especially if a patient is admitted. For patients that must be admitted, I have reason to believe that the potential for stereotyping, profiling, and stigmatization also exists on inpatient units. Because of the trend in hospitalists providing inpatient care, patients with sickle cell are likely to be admitted to medical surgical units. So, after IRB approval and each agency's research council approval, nurse managers sent the link to the survey to staff. The survey requested demographic information as well as completion of the clinician attitude scale and 3 adapted items from my own sickle cell health-related stigma scale. You can see that there are 4 subscales to the clinician's attitude scales, and I've included the reliabilities of each of those subscales in the current study. So, the result. Of the 78 nurses who responded, they were almost evenly divided between the ED, ICU, and medical surgical, with 53% being medical surgical nurses. 90% were female. Their average age was 38 years. Their years in nursing practice was 11 years, and most had been in their current practice area for about 8 years. Most of the nurses, or 61%, were baccalaureate prepared. The majority were white, 74%, and most were non-Hispanic. So, this was the main study question. Do medical surgical nurses and ED or ICU nurses differ in attitudes toward patients with sickle cell? Note that each of the attitude subscales range from 0 to 100. As reflected by the similar numbers, there was no significant difference between nurse attitudes by practice setting. And in this case, I would make the case that non-significant results are very significant. Even though there was no significant difference, it is worth noting that the most desirable attitude, a positive attitude, and of course the most expected attitude for a profession that is ranked to be the most trusted was the lowest in both cases, of course that being positive attitudes toward patients with sickle cell. Although not statistically significant, medical surgical nurses reported less negative attitudes, more positive attitudes, less concern-raising behaviors, and less red flag behaviors than ED or ICU nurses. When I looked at attitudes by education, some of the same trends appeared. We dichotomized education to associate degree or BSN or higher. There was not a statistically significant difference between these two groups. However, the more educated nurse tended to have less negative but also less positive attitudes compared to the associate degree prepared nurse. Note still that regardless of education, the most desirable attitude is the lowest, 30 and 24, respectively. The more educated nurses tended to note less concern-raising behaviors, but more red flag behaviors in patients with sickle cell disease compared to the associate degree prepared nurse. For the entire sample, the expected correlations between subscales of the clinician's attitude scale were supported and were statistically significant. Looking at the first row of data, nurses with higher negative attitudes were more likely to have lower positive attitudes, note more concern-raising behaviors, and higher red flag behaviors. On the second row, a similar trend, nurses who scored higher on concern-raising behaviors were likely to have less positive attitudes and higher red flag behaviors, as expected. Lastly, I examined relationships between nurse attitudes and the 3 stigma measures that I included. 2 of the items were significantly correlated with each of the 4 subscales from the clinician's attitude scale. On the first row, nurses who strongly disagree that patients with sickle cell disease use medication appropriately had higher negative attitude scores, lower positive attitude scores, higher concern-raising behavior scores, and higher red flag behavior scores. Similarly, on the second row, nurses who strongly disagree that patients with sickle cell disease do not complain about their illness any more than patients with other medical conditions had higher negative attitude scores, lower positive attitude scores, higher concern-raising behavior scores, and higher red flag behavior scores. These results bring the concepts of trust and credibility to mind. So, I'll wrap up this discussion of this study with a few comments that respondents were open enough to include in their survey response. These kinds of data often inform the interpretation of results and certainly give pause to the responses provided. Note that the underlying and bolding are my emphasis only. So, this nurse stated, "The majority of sickle cell patients I come across are hateful towards the staff. However, I have had some legit sickle cell patients that were really in crisis and did not exhibit drug-seeking behaviors and have been grateful for the pain relief that was provided and requested oxygen and fluids in conjunction with pain meds. The ones that I have felt were drug-seeking always got mad when IV fluids were ordered or oxygen was ordered, and if they didn't get the dose that they instructed the MD to order, they got mad, threatened to leave AMA. I feel that sickle cell is a painful and serious disease, but unfortunately, Those who abuse the system make it harder for those who are compliant and come in for a real crisis. These are the ones that go to the clinic, follow their regimen, see their PCPs. So, note who she is, a 32-year-old female, associate prepared nurse for 7 years. She works in either the ED or ICU has worked in the ED or ICU for the past 5 years. Her negative attitude score is 63. Her positive attitude lower at 31. She scored a perfect 100 on the concern-raising behaviors subscale and above 90, a 93 on the red flag behaviors subscale. So, this is one description. This second comment, it would be interesting to know how healthcare providers can adequately care for sickle cell patients without inappropriately administering narcotics, creating or encouraging their addiction. Rating pain at an 8 out of 10 when the patient is laughing, talking on the phone, and socializing with friends does not warrant additional doses of narcotics. There needs to be a better gauge than what the patient reports pain to be. Perhaps providers need to educate patients about the risk involved and the ease for a patient to develop an addiction. Note the prominent theme of addiction. So this is a 36-year-old female baccalaureate prepared nurse who's been a nurse for 6 years and has worked in the ED or ICU for 5 years. Her negative attitude score is 100, and along with her concern-raising behavior score of 100, a very low positive attitude score of 25, and a red flag behavior score of 67. So, along with a prominent theme of concerns about addiction, note also perhaps a lack of understanding of coping strategies of individuals who live with chronic pain, and the fact that she states that there's got to be a different way of adequately knowing how much narcotics to give other than the patient's own complaints of pain is quite interesting, considering all nurses are exposed to McCaffrey's words that pain is what the patient says it is. So, based on the comments of these two exemplars, what would be the potential of the patient being stigmatized by nurses that express these types of attitudes? So, non-significant results, like I said, can be very significant. Based on these results, nurses, not just ED nurses, need additional education in order to improve attitudes, because we know that clinician attitudes can influence the provision of care. Here are just a few suggested areas of emphasis. A better understanding of addiction versus dependence versus pseudo-addiction, more information on coping strategies, and a better understanding of challenges of care seeking for adults, in particular with sickle cell disease. So we know that we are more than 100 years beyond the initial description of sickle cell disease. As a nurse, I am proud that we are ranked as the most trusted profession. However, that should be reflected in our attitudes towards all patients. So now, let's discuss some additional recommendations. Education about the provision of care to patients with sickle cell disease is not prominent in nursing curricula, especially care of the adults with sickle cell disease. This seems to be a holdover from the past position that sickle cell was a pediatric condition, and we know that care of a pediatric patient for sickle cell disease and care of an adult with sickle cell disease present different challenges. So I provide a few examples of how nurses can enhance sickle cell education for perhaps their students and nurses in the profession. Especially for students, students need to be exposed to patients with sickle cell disease in clinical care. And this could be either in direct care assignments or collaboration with other members of the healthcare team. Additionally, individuals can include guest lectures from experts in sickle cell disease in formal classroom settings, either in hospitals, nurses and other providers, provide guest lectures for support groups, and certainly for conferences. For individuals living with sickle cell disease, they also need to become more involved in educating nurses and other healthcare professionals. I would suggest including individuals living with sickle cell disease in panel discussions, certainly include them on advisory boards, and include them in research whenever possible. And I think some of the newer research initiatives had made that case in having more patient-centered initiatives that demand the inclusion of patients in the development and conduct of research. So those of you who are nurses, what are you doing to educate future nurses and other healthcare providers about sickle cell disease? And for individuals living with sickle cell disease, think about ways that you can share your experiences. Some nurses never see individuals with sickle cell disease outside of the sick role, so they only have one perception, which obviously is not always an accurate perception. So, this slide highlights a video intervention to improve clinician attitudes toward patients with sickle cell disease, the results of a randomized experiment by Dr. Carlton Haywood and colleagues. The video used in this intervention, sometimes referred to as the TRUST DVD, fills the voice of nurses who never see patients outside of the sick role. Indeed, a picture is worth 1,000 words. This 2010 paper describes a video intervention to improve clinicians' attitude toward patients. Their intervention consisted of an 8-minute video that featured an adult hematologist and 3 adults living with sickle cell disease discussing the challenges that many individuals with sickle cell disease face when seeking treatment for pain. The results suggest that the attitudes of clinicians towards sickle cell patients may be improved through a short and relatively easy to implement intervention. So, as I mentioned, the number of hospitalists is increasing. Do hospitalists care for patients in your agency? What is a hospitalist? It's a physician that's employed by the hospital whose specialty is knowing how to coordinate and deliver hospital services most efficiently and mainly seeing inpatients. So what does this mean for individuals and families with sickle cell that the individual with sickle cell disease is more likely to be seen by a hospitalist as an inpatient provider than typically a hematologist? What does it mean for medical surgical nurses? In general, it means that hospitalists will admit those patients with sickle cell disease, the adults, to an inpatient unit that's typically a medical surgical unit, as opposed to an oncology unit, which was more likely to happen in the past. So, since more and more patients with sickle cell disease will be admitted to medical surgical units, med-surg nurses are looking for more information and education about patients with sickle cell disease. As a result of this trend, I was recently invited to present my research at a med-surg conference, and I ended my talk by showing Dr. Haywood and colleagues' 8-minute TRUST DVD. I asked the nurses to write down 2 to 3 words in response to the video, and this word cloud is a result of their responses. The prominent words speak for themselves and speak to the fact that many of them never had the perspective of a patient outside of the sick role. And I would emphasize some of the words. The most prominent ones was eye-opening. And then we have words like, or phrases like pain is subjective, be non-judgmental, everyone should see this. So once again, comparable to Dr. Haywood's finding, every nurse probably should see this DVD in order to give them some more perspective and perhaps inform their attitude toward this population. So, another possible way that nurses can decrease health-related stigma is by teaching patients SBAR and using it to communicate with patients with sickle cell. This article highlights how SBAR may benefit patients with sickle cell. So what is SBAR? Situation, background, assessment, recommendation, and response. It's almost considered the gold standard for healthcare providers. We know that communication failures harm patients. In fact, in 2005, 69% of the sentinel events reported had communication as their root cause. SBAR reduces communication failures. SBAR enhances the effectiveness of colleague-to-colleague communication in service of patients. Enhanced effectiveness means communication using a recognizable structure that improves safety, clarity, efficiency, and respect for the message sender and receiver. So, perhaps it can also enhance the effectiveness of patient-provider communication. SBAR can be introduced in nursing curricula as part of educating individuals who live with chronic disease to enhance self-care management. It can also be incorporated as part of the discharge teaching for individuals discharged from emergency departments or inpatient units. Another ideal time to teach SBAR would be in an outpatient clinic where most individuals are coming from maintenance and not an acute illness. In addition, SBAR could be incorporated into transition programs as individuals move into adult care. In this slide, I show an example of dialogue between a provider and an individual with sickle cell disease, going through situation, background, assessment, and recommendation. In recommending SBAR for patients, I'm not recommending something that I have not tested. Results from my own research, a longitudinal study that compared a care-seeking intervention focused on SBAR communication to an attention control condition, supported the intervention as efficacious in decreasing health-related stigma. Based on the mixed model repeated measures analysis, the change from baseline in health-related stigma total score to the end of session 2, a two-session intervention, was significantly greater for the care-seeking intervention group compared to the attention control group. Separation from the attention control on health-related stigma total score was observed from baseline but became more evident over time as the difference in means between the two groups widened. So the attention control group is on the top, represented by the top line, and the care-seeking intervention group focused on SBAR is on the bottom line. So, another possible solution to decreasing health-related stigma in individuals with sickle cell disease is to cultivate more of what has been described as sickle cell nurse champions. So, the purpose of a multidisciplinary sickle cell champion is to promote patient-centered best practices for persons with sickle cell disease seen across care settings, inpatient, outpatient, and emergency department. This program is being developed by Dr. Paula Tanabe in the Duke University Health System and being disseminated. The champion will express a commitment to promoting evidence-based standards and developing and implementing innovative, professional, evidence-based multidisciplinary care. Sickle cell champions serve as frontline educational resources and physician and nurse mentors for coworkers. In order to become a sickle cell champion, an individual has to attend a sickle cell workshop, attend quarterly sickle cell champion meetings that include sickle cell content updates. They serve as a role model, demonstrating excellent high-quality care. They promote and disseminate all sickle cell protocols and quality initiatives, quality improvement initiatives relevant to their patient care settings. They help to deliver educational content to peers, and they encourage the utilization of available sickle cell disease resources and protocols. They direct colleagues to online policies, process standards, and resources. So this is an emerging, developing role, and certainly one that we in ISNAPA hope to help Dr. Tanabe disseminate. So, speaking of ISNAPA, it's an organization that is a nonprofit organization established in 1990 to set and maintain high standards in the provision of care of individuals with sickle cell disease. Goals include maintaining and increasing the quality of individual health care service to patients with sickle cell disease through both individual study and collaborative clinical research studies, as well as through continuing education, providing sickle cell education to colleagues who work in clinics, health departments, and private practice settings, and also influence schools of nursing and physician assistant programs to enhance their sickle cell curriculum. So ISNAPA members that is prominently nurses, but also include other healthcare professionals, would like to be a part of decreasing health-related stigma and kind of in many ways pull all of the recommendations together and collaborate, and will be collaborating with colleagues to move their initiatives forward that are comparable to our own. So for additional information, I've put our email address and also our website on the slide. So if nurses do their part to become better educated and also to educate others, especially future nurses and healthcare providers about sickle cell, perhaps individuals and families will have improved positive pain management experience, have decreased health-related stigma, especially during care seeking, and also develop more helping, trusting relationships with healthcare providers. So I would like to thank the CDC Public Health webinar series on hemoglobinopathy selection committee for selecting this talk, ISNAPA, the International Association for Sickle Cell Nurses and Physician Assistants, for allowing me to present this content. And I've listed funding sources for the studies of my own that I discussed. And I would like to thank the UNC Chapel Hill Comprehensive Sickle Cell Program team. And last but not least, my colleague and friend, Dr. Cheryl Brewer, who is my right hand and does so many things to support the sickle cell community. And she's also a board member of ISNAPA. And that is my last slide, and I look forward to any discussion.
All right. Thank you so much, Dr. Jenerette. That was a great presentation. So at this time, we're going to be opening the lines for questions. Please remember to unmute your phone individually by pressing *6. If you do have a question, please raise your hand electronically, and your name will be called in the order that is received. We only have this line for another 25 minutes or so, and we'll have to end at that time. So again, if you have a question, you can either type it in on your screen, or you can just unmute your phone line and ask your question directly. Any questions from the audience? Actually, I do have one question, Dr. Jenerette. You mentioned a trust DVD by Dr. Hayward Jr. and his group. Do you know how people can get access to that? Is it online anywhere?
I have heard that it's actually online, but if you contact Dr. Carlton Hayward at Hopkins, he has been very open about sharing the DVD and sharing copies because it has had such an impact. So I'm sure he'd be happy to share it.
Okay, great. I actually do have his contact information. Presenter on our webinar series earlier this year.
Yes.
And so if I do get access to that, I'll be sure to send it as email blast to the group.
Wonderful. And he's shared the DVD at several of the major sickle cell conferences, too. So it has kind of gotten around the community, but of course there's still pockets of people that haven't seen it. But once they see it, they're quite impressed by the I guess the expressions from these people living with sickle cell disease, and actually the providers that are on the DVD also. So.
Excellent. And we do have one question, but someone's asking if they can have copies of these slides. As we do with all of the webinar presentations, we will make PDFs of the slides as well as the recording to this webinar available at scinfo.org. It usually takes anywhere from 2 to 4 weeks to get things up on the archive platform. So if you'll just be patient with us, it should be up before the next webinar presentation. Are there any other questions related to Dr. Jenerette's presentation today? Oh, okay.
Hello.
I'm sorry. Go ahead.
Hi. My name is Deborah McPhee, and this is actually the first time I'm participating or listening to one of the seminars, to which I've enjoyed. But I do have a question to Dr. Jenerette.
Yes.
And this is relating to, have you studied the staff's attitudes towards patients with sickle cell, say, in relation to the workload of the staff at the time?
No, I have not. What in particular are you emphasizing?
Well,
as far as staffing ratios, or with the integration of patients with sickle cell disease into med-surgical units, or
basically that. I think it is maybe the staffing may have something to do with it. I think, say at the beginning of the staff day, perhaps, people are fresh, and optimistic and ready to take care of the patients and all, but then as the workload or the responsibilities wane during the day, then it seems like the attitudes change. And I'm just wondering if that might have something to do, just like with anything else, even with children, when your own kids, you're fresh during the day, but then as the kids come home and you're tired from work responsibilities and all. And, it's been my experience that some of the patients, then our intentions are best. We have the patient's best interest at heart. We do, after a while, it seems as if, they do challenge the optimism. So I'm just wondering.
Well, I think you make certainly a very valid point. I would hope that staffing is still done by acuity, but then that raises the issue, are nurses, those in charge of doing staffing by acuity, are they actually rating the acuity of patients with sickle cell disease appropriately in order to match the right staff, the right ratio with their patient assignment? For those of us who've taken care of patients with sickle cell disease, they are very complex. The psychosocial needs sometimes outweigh the physiological needs, and sometimes they are very time-consuming. And if you have one patient in your assignment that needs 90% of your time for multiple reasons, then that can certainly, boost that patient up as far as being a difficult patient because they dominate your assignment. So I think you make a very valid point, and it would be interesting to do a study that looks at the acuity ratings or compare some acuity ratings between different clinicians and nurses to see if the patients are being assigned a correct acuity level in order to make the most appropriate staffing assignments, which would somewhat be equivalent or comparative to triaging patients with sickle cell disease. I think some individuals don't accurately understand the complexity of the disease, and therefore the patient either doesn't get triaged appropriately or likewise may not be assigned the correct acuity, and therefore that leads to problems down the road with the provision of care. So you make a very valid point, and that perhaps an interesting new way to explore one of the possible root causes for stigmatization. If you kind of start off with the wrong idea, then it's going to take a lot longer to get back on the right track. So thank you for that comment.
Thank you so much.
All right, excellent response. We have several questions online, so I'm going to read them out loud. Marcus Allen states, how receptive have schools of nursing and medical schools been regarding your wonderful message? I think that it would work for other diseases as well. So his question is, how receptive have schools of nursing, medical schools been regarding your message?
So, of course, I'm more linked to schools of nursing. My own school of nursing, University of North Carolina at Chapel Hill, has been very receptive to including more about sickle cell disease in the nursing curriculum. The first thing that I noticed once I arrived there was that we already had a physician providing the pathophysiological lecture about sickle cell disease in the patho class, which was quite impressive. But in the medical surgical courses, the adult courses, there was very little discussion about sickle cell disease until I came on board, and once other faculty realized what my program of research was, I started providing the content for talking about the anemias and including sickle cell, those types of things. I've also made an effort to, anytime a colleague sends out an email about a panel discussion or anything about chronic disease, I always try to make sure that I offer or suggest someone with sickle cell disease. So within my own little niche in the world, my own little corner, the school has been very receptive. Now, I've traveled and done some other talks nationally, and that's where I've interacted with more schools of medicine, and the physician, that's over another comprehensive sickle cell program, really enjoyed my program of research and my talk and things I had to say about SBAR. So I've, for the most part, I've received lots of positive comments, but I still think it's a hard battle to infuse a whole lot of content because curriculums are already packed, and in order to get something else in, you have to figure out what you can move or what you can decrease in order to increase other content. So I think it's an uphill battle, and we have to still think of creative ways to get the content into the curriculum.
Great, thank you for that. Sean Bediaco has a question. Well, first he says, great presentation, Dr. Jenerette. Do you think there is a need to examine individual differences in how sickle cell disease patients respond to stigma?
Hello, Dr. Bediaco. And yes, I agree. We share a common passion for studying health-related stigma. We come at it from different perspectives, Dr. Bediaco and I, but I think collaboratively we share some of the same ideas. And I think there is a need to look at things individually simply because of the fact that each individual is going to experience sickle cell disease differently with different complications, different complexities, and also experience the illness, their response to the disease differently. So I think there is a need to have multifaceted interventions in order to capture the essence of what each individual experiences and how to best help them.
Wonderful, thank you. Tyvana has a question. Why are sickle cell patients sent to med-surg versus oncology when admitted to the hospital?
I had that same question when I noticed that trend at my own facility, and I don't know the politically correct answer, but I do know that in general the patients seem to get more consistent, congruent care when they're cared for by the hospitalists, because the hospitalists have one team and they typically rotate, so it's more likely that the patients will encounter some of the same physicians that already know them very well, compared to being admitted to the oncology unit by the oncologist or hematologist, where the attending may be on call more inconsistently or more rarely, and therefore the patient may be less likely to be seen by a person that's I guess, more familiar with their care. Now, even though the patients are admitted to the hospitalist for inpatient care, it's not like they still do not have access to a hematologist or a pain specialist if that's needed beyond the scope of practice for the hospitalist. But it is a general trend that we're seeing that the patients are admitted to med-surg units and cared for by hospitalists as opposed to being admitted to oncology units.
Thank you. Very comprehensive response. The next question we have is from Yvonne Carroll. She says, this was wonderful. Did you have an ethnic or racial breakdown of staff and their attitudes towards patients with sickle cell disease? If so, was there a difference?
I included that on the demographic sheet, but I did not include that as a variable simply because the majority of the participants were Caucasian, so therefore there were not enough in the other categories to actually make any statistical conclusions. But we know from past research that the ethnicity has not made the difference that we thought it would. There's some data from a study with physicians where one might assume, because the majority of patients with sickle cell disease are Black or African American in the U.S., that Black physicians or providers may provide better care, perhaps be more empathetic, but that was not the case. So I would not be surprised if we found the same thing in nurses, but unfortunately in this sample, the nurse respondents were not diverse enough in order to do those analyses.
Great. Thank you for that response. Are there any other questions on the phone? If so, press *6 to individually unmute your line. Okay, and I think we've responded to all the questions that came across on the webinar. I'll give everyone one more opportunity if you have any questions at this time.
Or Shay, if anyone has any other examples of how they have done something within their agency to improve the education of nurses, that would be wonderful too in the last few minutes.
To unmute.
I thought I heard someone might have a question. Nope.
Hello, Dr. Kavanaugh?
Oh, do you have a question?
Yes,
Our
hi.
presenter on the line is Dr. Jenerette.
Jenerette, I'm so sorry. This is Bonnie Davis, and I'm here at Dallas at the UT Southwestern Medical Center. And I just want to go back to the question in reference to, patients, sickle cell patients being admitted to the hospitalist as opposed to an oncology unit. Now, I know here what our medical director has done is, try to make sure all of the patients, when they're admitted, they are admitted on an oncology unit, because she thinks that the oncology nurses are pretty much able to handle the pain management because they're oncology nurses and they deal with pain levels a little bit more differently than med-surg nurses. So that's what we've done. Having said that, many times our patients can't be admitted to the oncology unit, especially if there's an oncology patient being admitted for chemo and that bed is needed. But I know here in Dallas, the medical director has tried to assure that all of the sickle cell patients, if there is a bed available, she wants them on the oncology unit.
Thank you, Bonnie. So based on discussions I've had with different facilities in different areas, I think a lot of the determination about where the sickle cell patients are admitted are based on the culture of the facility and the leadership and the direction. So I agree, as my clinical background is in oncology, that oncology nurses typically would have more experience in managing pain and giving high doses and just in general comfort with giving high doses of narcotics. So in a recent article in CJON, the Clinical Journal of Oncology Nursing, I proposed that even if the patients aren't on an oncology unit, that the oncology nurses perhaps take some initiative in educating and being a resource for the medical surgical nurses, not because they are less than capable, but because in general they typically don't have the experience that the oncology nurses have. So if the oncology nurses could be a resource to the other medical surgical nurses, then as far as pain management and those types of things, that would be wonderful. But I certainly agree with you that the oncology units have a specific skill set that benefits the patient with sickle cell disease, but unfortunately it depends on the culture of the institution and the leadership as to where the patients are going to be admitted. And there's always overflow where hematology patients go other places, and sometimes oncology patients have to go other places and then be transferred. So. So thanks for sharing your experience at UT Dallas. So UT Southwest.
Okay, we just have about 8 minutes left. Are there any other questions before I move on to some announcements? Okay, well, thank you so much, Dr. Jenerette. The information was very helpful and very informative, and thank you so much for your time.
Thank you.
All righty, so our next webinar will take place on Thursday, August 22nd, and it'll be titled Mental Health and Learning Needs in Children with Sickle Cell Disease by Dr. Patricia Cavanaugh. And as part of our efforts to improve the webinar series, we will launch an online survey on Monday, July 29th. And we ask that everyone participate in this brief 7-question survey so we can incorporate as many opinions as possible into our plans for the 2014 webinar series. If you don't currently receive the webinar email blast from me, Shay Pope, please email me at spope@cdc.gov, and I'll be happy to add you to the list. Also, we are asking that if you have seen or heard any talks recently that you think would be beneficial for the series, you're more than welcome to send those recommendations to us, as well as contact information for a potential presenter. And finally, the recorded webinars are made available at scinfo.org under the webinars toolbar. Again, thank you, Dr. Jenerette, and thank you to all the participants, and I hope you all have a great day.
Thank you. Bye-bye.
Thank you.
Thank you.